So where are we going to go beyond here? Once we reach our destination, where do we go next? Or how do we improve it? So strategic planning, solution planning, and thus, if that's our strategic direction that we're going to go forward in the future, how are we going to get the money? Where is it going to come from? And when? So that investment. It clarifies roles and responsibilities and the business service. So it clarifies what's the responsibility of the LIN, what's the responsibility of eHealth, what's the responsibility of the organization, such as a hospital, a family physician's office, or a community care access center. So it defines all of those responsibilities and their mandate. Next slide, please. We want to make sure that everyone is in alignment. So the organizations that are involved in this local eHealth initiative are the local health integration networks. They have been working on the e-notification system to enhance the surgical wait list times. They've also been working on the e-screener, which will go into each one of these a little bit deeper. A group of organizations called a cluster came together to work on Clinical Connect and the HSIM. And there's been some provincial initiatives such as HealthLinks, IAR, OLAS, and e-consultation, telehome care, and the regional matching and referral service. Again, I'll go into a few of those in a little deeper in a few moments. So, checking in. Next slide, please. Your turn. What feature of the electronic health record is built on key foundational principles, including privacy and security, compliance, collaborative governance, regulation, and policy standards and federation? Give you a moment to think about that. Looking from the list, it is B, the eHealth blueprint that I've just been mentioning. So how is the electronic health record changing? These are the new elements that are currently in place. They're not in place for everyone everywhere yet, but they're beginning. They're pilot programs, if you wish. The e-notification that Spire mentioned last week, when a family physician gets notified that one of their patients is in the hospital, where they've registered into an emergency room, then the family physician now is e-notified of that. They're also e-notified when they're discharged, and they get a copy of the discharge summary. There's the e-screener, the telehome care for folks to be able to communicate remotely to a healthcare provider, the surgical waitlist repositories, the Ontario Laboratory Information System, and that regional matching and referral service. Again, we'll go into those a little bit deeper. Let's start with e-notification. So if you're a client of Community Care Access Center, and you go to an emergency department, both the hospital and the Community Care Access Center staff will be automatically notified. So in terms of the community care, it could be, again, a nurse that's been doing a dressing change. It could be a PSW, a personal service worker, who's been coming to help you do some daily living activities like cooking and cleaning, etc. If they're a member of the Community Care Access team, then they will automatically be notified that one of their clients has gone to the emergency room. So that's the e-notification system. Next slide, please. What is the e-screener? The e-screener, if you go to an emergency with a complex healthcare need, a referral to Community Care Access Center starts right away, because the assumption is when you go home, when you eventually go home, if you go home, you might need to be placed somewhere else first before you transition to home. Or if you do go home, you might need some supports in place. And so that's more complex. It could involve, as I said, a personal service worker, a nurse. It could involve a nutritionist. It could involve a physiotherapist while you're at home. Also, there are locations where patients will go after they have acute care, but they're not ready to go home yet. So they'll go to a place in between. And we have, in London, we have a few of those locations. One is at Parkwood Institute, located on Commissioners Road. I'll give you the example of my father-in-law. He had a fracture at the top of his fibula right by his hip just before the holiday time, just in December. He came in to the hospital, he was treated by the orthopedic surgery team, and then he wasn't ready to go home yet because he hadn't fully had his full rehabilitation. So he went to the Parkwood Institute to a rehab bed, and he stayed there 26 days while they actively worked on his physiotherapy and his return to home on things that he could do, and gave him some supports in place. So initially it was a walker, and later on he transitioned to a cane. What is tele-home care? If you live and are managing a chronic care illness, you may be able to stay at home but be connected remotely to a nurse practitioner who's running that clinic, and perhaps a physician who's in touch with a physician on a daily basis. So one example of that is we have a cardiac heart failure clinic that's located out of St. Joseph's. The nurse practitioner is in St. Joseph's Hospital, but the majority of her work is done over the phone or via teleconference. If she needs to bring the patient in, she will, but if it's not necessary, they can certainly stay at home, and she can communicate with them and manage their care remotely. Next slide, please. The surgical waitlist initiative is to centralize the information in a repository to aid in the ministry reporting of wait 1 and wait 2. So wait 1 is wait 1 and wait 2 is a triage system, so that we can triage who are the most urgent patients versus the immediate patients. So with immediate, I've broken my hip, I need to get it fixed now. Whereas somebody who's urgent but not immediate means that I need to get it fixed within about a month or so, and there's danger of perhaps it becoming infected. Therefore, I need to sort of an urgent appointment, but it's not an immediate trauma. So we want to be mapping the different levels of care so that we can get the right care for the right patient at the right time in the right place. Next slide, please. OLIS is the acronym for the Ontario Laboratory Information System. It is a repository of lab results from hospitals and from community labs. So that would include Dynacare and Life Labs. And that information is available to multiple services, to hospitals, to family physicians. For us, we view it through Clinical Connect. For patients can go in to look up their own lab results online at either Gamma Dynacare or the OLIS, or the Life Labs. So it's becoming more available to patients. We're not there yet with imaging. Both services require interpretation of the results. With the OLIS, there is some links to some online resources when the patient's lab results either are high or low. And then, of course, there's notification to whoever is the ordering physician if it's a critical result. But if it's high or low, and I wanted to look up information about that, what could it possibly be, so I have informed care, there's a link, and there's information about that right in the Life Lab system or the Dynacare system. So more patients are getting available to that kind of service and that kind of care. Again, we're not there yet with diagnostic imaging, but I think it will get there in the next few years. Whereas a result will come back from maybe a chest x-ray I've had, or an x-ray I've had on my knee or my ankle or what have you. And the result, I could go in, if I had a patient portal, I could look at the radiology report and then perhaps look at evidence or documentation about that condition. So again, we're not there yet, but I think we will get there. And similarly with the cardiology systems that we have. Next slide, please. The other initiative is the resource matching and referral system. So it's the ability to appropriately match electronic referrals that will move patients out of acute facilities and into more appropriate environments for their ongoing care using standardized tools. So this I can see as a great tool for mental health. Depending on the condition of the patient, they may not need to see a psychiatrist. They may not need to see a psychologist. It might be a social worker. Similarly, with some other chronic conditions, it could be that I don't need to see a neurosurgeon for my back pain yet. Maybe it's some active physiotherapy that I need. But without the resource matching and referral service, right now it's very cumbersome to figure all of that out. So the ability to connect people, acute to rehab, to community care continuum, to long-term care, to community care access in the home. So making sure that all the information is flowing, because that is a typical flow from an inpatient stay. So an acute would be the hospital, to the rehab facility, perhaps that I mentioned with my father-in-law, to the continuing care continuum, so the nursing staff, the physiotherapist, the occupational therapist. Then perhaps if the patient can't go home, then it might be a long-term care facility with community care coming in, or maybe going home and having community care in the household. Next slide, please. Another checkpoint, definition of OLIS, the Ontario Laboratory Information System. Is it the ability to appropriately match electronic referrals that will move patients out of acute facilities and into more appropriate environments for ongoing care using standardized tools? Is that true? Is that false for OLIS? Give you a second to think about that. The answer is false. It does stand for the Ontario Laboratory System, which is a repository of lab results from hospital and community labs such as Life Labs and Dynacare. Skip 2 slides, please. So the current state assessment. We've been working towards some of these projects, and some of the projects are implemented to a degree, but not to a full degree. Again, the goals are consistent with the Canada Health Infoway. It's to reduce wait times, to improve access to care, and not only here in London, but also the remote and rural communities. So north of London, so as not very far even, to places like Lucan, Ilderton, Grand Bend, and south of us too, in some of the more remote communities, such as Shedden, even Glenworth, Port Stanley. We want to make sure that we are improving access for folks who are in rural and remote communities, and just even in our region. And we're not talking necessarily way up north, 5 to 6 hours away, although we do focus on those as well. We want to increase the patient participation, and patients want that. And so we want to find ways to constantly involve patients in their care. Efficient chronic disease management. More and more patients in the London area, in Ontario, are developing chronic diseases. So we want to also minimize fewer adverse drug reactions. With the use of electronic health record systems, we should be able to do that. I know we've done that in the hospital system in the last 4 years by introducing computerized provider order entry. So no longer does a pharmacist need to decipher what that scribble was on that piece of paper and perhaps mix up, was that 0.25 milligrams or was that 25 milligrams, 25 milligrams? And is that, are they mentioning left side or is that right side, and trying to decipher their handwriting? So we want better prescribing practices, and we do that by having it electronic and having no variance in what is called for. If it's if a certain condition is managed with this specific medication at this specific dose, maybe varying a little bit by the patient's height and weight, but there would be options for people to choose. Under 100 pounds, over 100 pounds, over 200 pounds, etc. So there's very little variance there. It would be more focused towards what the patient needs and how the patient can handle that medication. Next slide, please. The triple aim, similar to the Canada Health Infoway, of course, very consistent, is to improve access to the information contained within systems. So better information, better navigation, and better communication of systems going across various areas. Improved productivity. So we want to improve the user experience, so the clinician's experience, the patient's experience. We want to decrease the number of duplicate tests that are ordered, reduce costs of managing paper records, and improving improved cost efficiency, and shifting resources where necessary, where they're not needed, and maybe redesigning or redirecting them to more appropriate places. In terms of reduced duplicate tests, one of the things that I teach our residents, our medical students, is how to prevent duplicate tests. I show them different tools in our electronic health records where they can look at their own orders that they're putting in, and then also bring up another screen that shows them if there's a duplicate. And we can also put into that the alerts. If there's a direct duplicate with the same medication, the same dose, the same route, the same frequency, it will generate an automatic alert. But if it's not the exact same, it won't. So if I have 20 milligrams of Lasix administered oral, and then I'm in the hospital and I get 20 milligrams of Lasix administered IV, that's not going to generate a result because IV is a different route than oral. So I show them a feature where they can check to say, hey, did somebody else already order Lasix? And if so, which one do I want to continue? Which do I want it administered group third in terms of the IV, or is the patient still able to get it orally? So there's different tools that can be deployed for physicians to be able to do that. In terms of duplication of tests, I also show them how to ensure that all of their tests are going on one label so that somebody doesn't miss the fact that somebody has already ordered that test. So if a CBC is ordered individually and not grouped with the other tests, I may miss that's been previously ordered. Hopefully the nurse will catch it and not prick the patient twice, but you know what, they're guessing, and they may think that the physician wants this done twice. So that there is that constant need to check in on things that don't look right. In terms of patient safety, those of course would be issues of patient safety, as if we were pricking the patient twice unnecessarily, if we were radiating them unnecessarily more than one time, if we were giving them improper medication or doubling up on doses, we could potentially have a fatal error. So we want to make sure that we're taking a look at all of those things and improving the patient safety experience. Next slide, please. The current state of how most healthcare system providers communicate is very fragmented, and it happens to be with little integration with provincial registries. It's very siloed currently. There's local facilities with local information and not talking to each other. And this prevents good quality patient care. So we want to make sure that the information is free-flowing through a provincial electronic health record. We want to make sure that there's the appropriate privacy and security controls on that information, leading to the enforcement of policy and solutions. One of the videos I showed you was of the nurse in one of the hospitals in Toronto who was selling the information to companies who would then sell the patient the RESPs. So she was giving lists of patients who had recently had children in order for this company to be able to sell them registered education retirement plan, savings plans. So that shouldn't happen. That nurse shouldn't be able to do that. So we want to make sure that those security controls are in place. We want to make sure the EHR content is diverse, but it has different elements, but we don't want it fragmented. We want to make sure that we have the collaboration and the training for folks to use the electronic health record system. As I mentioned, I'm one of the principal trainers, well, I am the principal trainer for the London Health Sciences Centre and St. Joseph's Healthcare for all of the physicians on our electronic health record. The reason that it is centralized in our office is because we want to make sure that that training is standardized, that they're not getting different messages from different people, and they're not learning other people's bad habits. So it's a standard message, a standard methodology that all of those folks in all of those groups get. So it's not different for resident X in orthopedics versus resident X Y in internal medicine. Yes, the medications might be different, some of the orders that they place are different, but the way they order is consistent and standardized. Next slide, please. So the future state of how health service providers will communicate is with reliable, safe information in a provincial, with using provincial registries and having a provincial electronic health record. We're getting there, again, but we're not quite there. We want to have also those security access layers in place to support privacy and security policies. So each of the individual areas should have a security and a privacy policy. So regardless of whether that is a Crescent Care long-term care facility, or whether that's a physiotherapist office, or whether that's an ophthalmologist office, or whether that's a hospital system. We should all have those security policies and the privacy policies in place. The electronic health record data set represents the longitudinal client record. So what we mean by that is being able to look over time. Locally in London, we've had an electronic health record in place since 1996, so we can view patient information longitudinally, but only since 1996. So yeah, so that would be 22 years. But that's better than some places. We have been very lucky to have that. And it's been a consistent system. It has been PowerChart for all of that time. There have been sort of ancillary other systems that have connected through it. As I mentioned, the GE imaging system, we've now gone to an AGFA PAC system, but the information is flowing seamlessly. What was through a GE system, now to the AGFA PACs, and it all flows into PowerChart. Next slide, please. The future. The future is vast. There's lots of opportunity for improvement of the electronic health record system, for additional elements to be added to the electronic health record system, and to connect people. So clients and providers will be informed through a timely access to all relevant clinical information, empowered by advanced power-operated systems, and protected by solutions that ensure their safety and privacy. That's a tall ask. That is a huge amount of work. And so it is going to take years for this to happen, but little by little we can see it happening. And as you watched on the videos, some of the videos I showed you last week, it is starting to happen where primary care providers are getting more access to more information in a timely way. Last week, if you recall, there was a family doc who was treating a patient and they needed a referral to a dermatologist. She quickly went and did the order for the e-consult, and that rheumatologist connected back with her by midnight that night. So that wouldn't normally happen. That would take, weeks to happen. But she was able to then connect with the patient over the weekend and see the patient on the Monday morning and redirect the care. So that's how quickly it can happen. The future architecture describes how local, regional, and provincial investments will connect to enable the safest and the best and cost-effective healthcare. So we have to make sure that we are accountable to the dollars that we're accountable to governments who are giving us the monies to spend on these systems. We want to make sure that it is standard architecture, that it's an efficient architecture, and that it meets the requirements of the local needs. Next slide, please. Going a little bit deeper into southwestern Ontario, I've been talking about the provincial level, and last week we talked about the national level, specifically around London, southwestern Ontario. There is an initiative called Connecting Southwestern Ontario. So in the Southwest, we serve 944,852 residents who could then become patients across 8 counties spanning 21,865 square kilometers. It includes Grey Bruce, so Bruce County, Grey County, Huron County, Perth counties, Middlesex, Oxford, Elgin, and Norfolk counties. For planning purposes, these counties have been segmented into 3 subsections. So we have the subsection here with Bruce and Grey. We have the Central County, which is Huron and Perth, and the South County, which is Elgin, Middlesex, Oxford, and Norfolk counties. The reason it's including Norfolk is because we have a connection with Listowel Memorial and Tillsonburg Hospital. Next slide, please. So the overview of the Southwest LHIN. So the Southwest LHIN is part of the Connecting Southwestern Ontario. So it's the funder of the initiatives that we have. It includes 19 public hospitals, operating 30 sites. So as I mentioned, even in London here, we have London Health Sciences Centre, which is made up of 2 hospitals, main hospitals, but we have some community sites as well. We have a cardiology center on Pall Mall Ave. We have a pain center, a pain clinic on Adelaide Street. We have a nephrology kidney clinic in Westmount Mall. So we have a number of other sites where we provide care. And there's 1 private hospital. We have 62 community support services, 4 community health centers, 28 mental health agencies, 10 agencies providing addiction services, 76 long-term care homes, and 1 community care access center for the Southwest region. Next slide, please. The challenges. Aging population is one of the challenges. So today's healthcare system isn't able to keep up with all the data that's needed with an aging population, with increased chronic conditions. And there may be new emerging challenges that we don't even know about yet. So there may be another pandemic of some sort that might arise. So different kinds of challenges, and so we have to be on top of them all the time and making sure that our information flow is efficient. It wasn't in the area of SARS. When we went through SARS, I don't know how many years ago that was, but certainly more than 12 years ago, we didn't have the robust information systems that we have now. And so, we get new challenges all the time. The LHIN itself, that geographic region, the geography alone presents a challenge because it's such a vast geographic region. So some people who live in Tillsonburg may not be able to access the services of our regional oncology center. That's at least probably an hour and a half drive away. And so if I'm an aging adult, say of 86, 90 years old, am I going to be able to get in my car and drive to London? Do I have family members who can help me get into my car and drive to London, or to drive me to London? I might be just a person without any family members available to do that. So we need to redesign what we currently do. And it's very, very, very much centralized now, so there's more of an initiative to have more services at the point of care, of where the patient lives and resides. It doesn't always have to be the large center that they need to come to. So the Southwest eHealth Strategic Plan is focusing on also our growing unemployment rate. So with people unemployed, they may not be able to have access to the medications that they might need because they're not on insurance plans that they would have with their employer. They may have an adverse effect on select populations, increasing need for mental health, addiction, and other services beyond capacity. So locally, you might be hearing in the newspaper that there's quite a bit of focus on preventing addictions to fentanyl, to carfentanil, to hydromorph, to OxyContin. And so we're constantly faced with some of those new challenges. And we want to make sure that the information is helping prevent those addictions and not supporting those addictions. There is an aging population. The baby boomers are now hitting, I think the lowest level of the baby boomer generation is now 54. So it ranges from 54, I believe, to 74 is the baby boom generation. And so they're aging, but they're living longer. And so we want to make sure that we're providing supports in place for people to be partners in their own care and to get the resources that they need it when they need it. And that's only going to continue to grow in the future. There's a high prevalence of chronic disease, which we know about in southwestern Ontario, and we want to make sure that that's managed appropriately. So if I do have a condition such as I've had some heart failure and a chronic heart disease, can that be managed at home? Do I need to see a cardiologist? Maybe initially, yes, but in terms of my follow-up care, maybe it's a nurse practitioner who specializes in cardiology and cardiac services. Next slide, please. So our local project here is called Connecting Southwestern Ontario, and it's in the process of integrating the healthcare systems from Erie St. Clair, Hamilton, Niagara, Haldimand, Brett, and the Southwest and Waterloo, Wellington local health integration networks. We are fairly connected here in the London area, but we're not yet connected to Hamilton and to Brett and to some of the other areas. We are through Clinical Connect through the hospital systems, but not to the community systems. And so we want to make sure we get them connected and then we can connect to them. We want to build on success and investments that have already been made in local, regional, and provincial initiatives. So as I mentioned, I'm in a regular contact with other areas, with other provinces, and we want to make sure that we are sharing best practices, and we're also sharing what the challenges were so that people can mitigate for those challenges in implementing electronic health records. It's working closely with stakeholders to address specific local and regional needs and to allow the electronic patient health information to be seamlessly shared. When it's complete, the project is meant to have a robust, scalable, reusable building blocks which can be used in other jurisdictions. So again, we can share information and also not reinvent the wheel. If this is how we implemented this project and it worked in terms of implementing a health record system, why wouldn't another healthcare provider or jurisdiction look at that and say, would this work here? It may work, it may not. They might have to tweak it, but at least they wouldn't have to start from scratch. So ultimately, we want to be capable of exchanging clinical data for better, timelier, and more managed care, accelerating the delivery of that information through an electronic health record. Next slide, please. So what is the goal? The goal of the CSWO, which I call it, is Connecting Southwestern Ontario, is to have individuals' health information from across the continuum of care, so right from a family doc's office and community care to acute care in the hospital, available and timely in a secure fashion. To have an integrated health record and a regional viewer, because not only do our patients come from the local area, they also come to our hospitals from regional to see a regional service, like our regional cancer program. And we have also a regional mental health center down towards Port Stanley. We have a Southwestern Ontario Forensic Mental Health Center.